Hello, everybody, and welcome to the Hughes Clues Final Exam Review. This is part 1B, and we're going to continue where we left off regarding the topic of hemodynamics. Now let's look at this hemodynamic value listing. You can pause the recording and then let's figure out what's going on and then determine what the fix should be. And when we look at the values, you see or you notice that the CVP is 15 and the pulmonary artery diastolic pressure, that's number 20, the number 25, both of those are elevated. And as I've mentioned before, it's very important that you look at the values that indicate volume first, because that's the first thing you want to identify. Is this patient either volume depleted, not enough volume, or are they volume overloaded? And because the CVP is elevated, the PAD is elevated, you identify, or you should have identified, that this patient has too much blood volume. They have hypervolemia. But look, we notice that the cardiac index, the cardiac output, adjusted for height and weight, is low. And truly, because the heart's job is to pump whatever volume returns to it, the heart should be pumping out an adequate cardiac output in the presence of adequate amount of volume. And because the cardiac index is low in the presence of lots and lots of volume, then you know that this is a contractility issue. So when there's lots of volume or plenty of volume and there's not enough contractility, not enough cardiac output, the contractility is low. That is the primary problem. When you see that the SVR is elevated, that is because of a means of compensation. The cardiac output goes down, and therefore the body will compensate by vasoconstriction when the cardiac output is less than adequate. And you notice that the heart rate is elevated. Again, both of these are compensatory mechanisms because the cardiac output is down. Now, they're not good for the heart for these things to occur, but because truly the primary problem is overload, is too much volume that is causing too much work for the heart, the first fix is going to be to get rid of the excess volume. Yes, we do have a contractility issue, but the excess volume is overloading the weak heart, and therefore really the first fix for a patient is that we need to get rid of some of the volume. Here's all of the interpretation of these hemodynamic values, because this really represents cardiogenic shock. So I'm not going to go over this again. All of the words are there. And when we look at our hemodynamic principles, we've already identified that if the tank is empty, fill it with fluids, and then there's your options for fluids. And then we just identified that if the tank is full, you want to empty it. And the drug of choice to empty the tank is diuretics. Now let's look at this new value. We've got a CVP of 8 and a pulmonary artery diastolic pressure of 14. And you might be saying to yourself, hey, the volume is high. The PAD is a little bit high. And the reason why I have this in a blue letter or in a blue font is because I want you to realize that trickery occurs on nursing exams. This probably is a no-dust statement for you. But sometimes these values are just a little bit slightly elevated or a little bit slightly decreased. And what I want you to do is consider them. Consider those values that are truly abnormal per our criteria, but also keep moving on and keep looking at some other values to see, you know what, do I have the drama factor is what I call it. Is there something that's really, really low or really, really high to where I really shouldn't focus on that slightly elevated value of the PAD? And as we carry on and in interpreting this hemodynamic value data, we notice, you know what, the cardiac index is still really low. Cardiac output is still low, even though we have a reduction in overload. We still have normal volume, so by By true definition, the heart should be pumping an adequate cardiac output, and because the heart is not, even in the presence of adequate or normal volume status, we know that this is a contractility issue. Now we can go ahead and apply or administer some kind of positive inotropic drug. And I'll show you a list of them in a little bit later on a slide down. Try and figure that one out. Well, what are my positive inotropic drugs? So this patient now is ready to have a positive inotrope. And then as we look at the next slide, let's say that this patient, the scenario read that the patient has been given a diuretic. A positive inotrope was started. What's an additional fix that could be applied or given to this patient? And you see that we still do have an elevated systemic vascular resistance. And when you think about the heart's ability to pump, especially when the heart is in cardiogenic shock and therefore weak and not as strong as it could be, you know that a vasoconstricted artery is going to create extra workload. That is going to offer a whole lot more resistance to the heart, and when the heart is weak, that could be the heart's somewhat undoing. So we do need to fix this elevated SVR, and to do that, we're going to give some vasodilators. So again, we're going to apply the rules that if there is a contractility issue, as what we previously identified, we know that we need to give a positive inotropic drug. And here is the listing of the positive inotropes. Now, I do want to point out that a couple of these drugs do have more than one action. So you might remember or recall that dopamine is also a vasoconstrictor. It is dose dependent, and because you are not responsible in this course for understanding or knowing what the dosage is, you just have to think, well, in the scenario that Dr. Reed gives me, is this dopamine? Is the dopamine acting as a vasoconstrictor or pressor, or is the dopamine acting as a positive inotrope? So you just have to keep that in the back of your mind. Epinephrine also will increase the heart rate. It does several different things because it's also a beta agonist, so we give it in other scenarios such as anaphylactic reactions. So just consider that. And then on the other hand, let's talk about vasodilators, because we know that if the SVR is profoundly constricted, if the artery is constricted as evidenced by an elevated SVR, that causes an increase on the heart's workload, so we could give a vasodilator to decrease the heart workload. And arterial vasodilators are nipride and cardine. Nicardipine or nitroprusside are the generic names. Now, nitroglycerin is a vasodilator, but I want you just to remember that it dilates the venous system. So it's not going to really fix the systemic vascular resistance value, but it will reduce preload. So in a scenario where you have you're asked, well, how does vaso or nitroglycerin help? Well, we know that it dilates the venous system, so therefore it reduces venous return by vasodilating the veins, and therefore blood is going to stay down in the feet instead of returning to the heart. And that in and of itself will definitely decrease the workload of the heart. So nitroglycerin is helpful, but it helps in a little bit different way than the arterial vasodilators. And so I've kind of separated that out. That's pretty much all I think you really need to get from the hemodynamic portion. I don't think that there's going to be very many questions on the final exam on hemodynamics. There might be 2 or 3, and I think you're going to be able to figure them out fairly easily with this pretty brief review. On HESI, it's likely that you'll be asked about the CVP. You truly usually are not asked about the pulmonary artery wedge pressure because those aren't things that are taught in every nursing program's courses, and you're likely not to see those concepts on NCLEX. Not likely, you won't. You won't see those concepts on NCLEX. So HESI doesn't usually cover those things. We're going to move on to different shock state, and that's obstructive shock. So this is kind of the shock state that's not often talked about. It's a little bit more confusing because it is a problem, obviously, for a patient. It can be deadly for a patient, but the problem is truly something that's a pathology that has abnormally occurred. And because it has, truly anything considered an obstructive state is obstructing the heart or preventing the heart from filling or pumping. So you have something physically there that is preventing the heart from doing its job. Probably the most common one that you'll be asked about is cardiac tamponade. And when you look at that, what has happened is there has been, instead of the normal 50 mils of fluid that's in the pericardial space, you have a collection of either blood or a whole lot of lymph fluid that's in the pericardial space. And that presence of a lot more fluid than what is normally present is what is causing the heart or decreasing the heart's ability to fill and therefore contract normally. Notice the signs and symptoms if you're trying to be led to a problem with cardiac tamponade. You have JVD, muffled heart tones, and narrowed pulse pressure. If you're not sure what narrowed pulse pressure is, then go back to the obstructive, the long presentation that I did on the obstructive shock, because I just don't want to revisit it today so that I just beat you to death with information. So again, to summarize, with obstructive shock, you're going to have a physical obstruction that impedes the filling or the outflow of blood to or from the heart. That's the perfect definition of obstructive shock. Cardiac output's going to go down, and therefore the heart or the blood pressure will go down. Heart rate, is probably going to go up initially. Characteristics are going to vary because you've got all kinds of different obstructive shocks. So it's unlikely you'll get any hemodynamic data with obstructive shock. I will say there is one thing that might be thrown at you on your final critical care final, and that's that all the hemodynamic data is going to be elevated. Look at some other major causes of obstructive shock, and that's tension pneumothorax and a massive pulmonary embolus. Moving on to distributive shock. There are three types of distributive shock: anaphylaxis, neurogenic shock, and I just drew a blank. Maldistributive or distributive shock. The first one that we're going to, and sepsis, hello. The first one we're going to talk about is anaphylaxis, and this is some kind of problem where a drug, pollen, bee stings, blood, food allergies, transfusion reaction, there's a whole gamut of things that can contribute to a systemic anaphylactic reaction. You're going to have massive systemic vasodilation, which is present in all distributive shocks. Again, massive systemic vasodilation. Heart rate's going to go up in a couple of the distributive shocks. We'll talk about the exceptions in just a minute. And then you can see with anaphylaxis, you have all the signs and symptoms kind of pictured here. What is the treatment for airway management? And that is epinephrine. It can be given sub-Q or IV. What does epinephrine do in this instance? Well, it causes vasoconstriction, usually of the coronary arteries, and it will cause bronchodilation. And this is constriction is caused by the inflammatory mediators. I probably have to say to you, your hallmark characteristics truly for an anaphylactic reaction is that you're going to have the history that the patient had something to eat or was exposed to some kind of pollen walking through a field of flowers, and that the patient has wheezing, because there are not really any other shock states where you get wheezing. So I would really truly link wheezing, if that's your assessment characteristics that you're given in the exam item. I would say, you know what, this is probably trying to lead me to anaphylactic shock. Again, you've got another type of distributive shock that is called neurogenic shock. We all have heard about that when we did the spinal cord injury. Again, you have massive vasodilation, and this is because there is a loss of sympathetic tone. You have the loss of the sympathetic nervous system because the cord. And when you have a loss of the sympathetic nervous system and its mediators, which are epinephrine and norepinephrine, you are going to therefore have the parasympathetic that's going to take over. So you do not have epinephrine, norepinephrine. You have the parasympathetic that is now in charge. And because the parasympathetic is in charge, that is your rest and digest, you're going to have a low heart rate. So this is truly the only shock state that is unable to compensate. You will have a decreased heart rate. And that should be your key clue, besides the history of the patient, that you have neurogenic shock, that decreased heart rate. What's the treatment? Well, the primary treatment, because you can't or don't have the ability to compensate, the patient's going to need to get atropine. And the blood pressure will be low because of vasodilation, but if we can sometimes give the atropine, then the blood pressure can normalize. However, be sure that if the blood pressure doesn't, if you've given all the atropine that you're allowed to give, the blood pressure is still low, you're going to need to go straight to a vasoconstrictor, a vasopressor. Now, I do say that when you have massive vasodilation, you have what's known as relative hypovolemia, meaning if you normally have 5 liters in the vascular space and now you have massive vasodilation, the tank, the vascular space, is now a whole lot bigger. We could say that it's at a 7-liter range. There is some textbooks that will say, well, go ahead and fill the tank. So that's a consideration. But in your textbook, it says caution, caution. It may be that fluid needs to be given. It may not. So in the option where you can give some fluid, I would give some fluid. That's what I've usually seen. But truly, if the blood pressure is still very, very low in the presence of a normal heart rate, then you're going to have to give some kind of vasopressor. Well, what's the vasopressors? Well, your vasopressors are neosynephrine, which is phenylephrine, levofled, norepinephrine, dopamine. And again, this is where I say to you, remember, your dopamine's a positive inotrope, but in large or higher doses, it's a vasoconstrictor, and then also vasopressins. So that's the options that you can pick for your vasopressor once you have given the atropine. Now we're going to move on to septic shock, another type of distributive shock. And before we talk about sepsis, we have to talk about what the warning signs of sepsis are, and that's SIRS. When an individual presents to the hospital, and let's say they have pneumonia, or in this case, they have cellulitis because they're an IV drug abuser, and the nurse notices that the heart rate has gone up and that the respiratory rate is very rapid, that they kind of have altered mental status, then you have to identify, you know what, this patient has SIRS. So this slide represents all the signs and symptoms or what are identified as SIR. And in the presence of infection and the presence of 2 or more signs and symptoms that I just showed you on the next slide, those are the signs and symptoms. Then the patient has SIRS, and that is identified as sepsis. If you have sepsis and a low blood pressure, now you have septic shock. So I can't say it enough that with any patient in the hospital, because they are at risk for infection or they truly already have a diagnosed infection, you have to be on the lookout for SIRS and therefore sepsis, because mechanisms are in place. These hospitals all have treatment protocols that when the nurse identifies SIRS and the patient is either at risk for infection or has an infection, then the nurse will deploy the treatment protocol or the sepsis protocol, which is to give a whole lot of fluids, do cultures, etc., etc., etc. And that is all to prevent septic shock from occurring, because of course the mortality rate for septic shock is very high, and we don't want that patient to get to that stage of septic shock. So here's what I've got. Treatment. We're going to give fluids because, again, these patients have massive vasodilation, so they're going to get a lot of fluids so that we can fill the tank. And then they're going to have cultures that are going to be initiated before antibiotics are started. But the key thing is, if there's problems getting all of the different cultures, you cannot delay the antibiotics. Most hospital protocols will say, well, you know what, you've got to give the antibiotics within a certain time frame, so we don't delay the antibiotics. When I talk about septic shock, we really do divide it into two stages. The warm stage of septic shock, which is seen first, and then we have the cold stage. Notice that in the warm stage, your key hemodynamic data is going to be an elevated or increased cardiac index or increased cardiac output. Your SVR will be low because always with septic shock, distributive shock, you're going to have massive vasodilation, but you're going to see a high cardiac output, and you also will frequently have a normal urine output. And the patient will kind of chug along in this. This is kind of like the warning sign that should indicate to the nurse that septic shock cold stage is just around the corner. So this is the time when the nurse should deploy all those mechanisms to ensure that the patient gets antibiotics, gets enough fluids to fill the tank so that we can prevent the low blood pressure. And once the low blood pressure occurs, and the tank is definitely full, as evidenced by a normal CVP and PAWP, now it's going to be time for the nurse to give vasopressors. And we've already identified what those vasopressors are. So in summary, for an individual that comes in to the hospital for any problem, always think that there is a possibility of infection. If the patient has already a known infection, then they're just that much more obvious. Look for signs and symptoms of SIRS, and when you have possible infection or confirmed infection plus the two signs and symptoms of SIRS, now you have sepsis. You initiate the sepsis protocol, which is usually let's do cultures, let's give IV fluids, and you want to be on the lookout for low blood pressure. When they're in the low blood pressure, then we know that they're in the cold stage, and then we're going to have to do vasopressins. Now, there is usually one question in the semester, and I don't know at this point whether you've had that question or not, but there's usually one question about venous oxygen saturation. I want you to be aware that there's a problem, or when you see a low venous oxygen saturation in the presence of tissue or will cause tissue hypoxia. I'm sorry, I'm having trouble here with my thoughts. So here we go. Let's say that you have a sepsis scenario. The patient has low blood pressure. As we've identified earlier, there is a map of 70, 65, some books say, needed for that oxygen to leave the hemoglobin and enter the cell. If that oxygen, for whatever reason, is not leaving the hemoglobin and entering the cell, you're going to have tissue hypoxia. Therefore, it is always a bad sign when you have an arterial blood gas saturation that's at 100% and you have a venous oxygen saturation that's at 99%. That tells you what has happened is that from the arterial side, oxygen did not leave the hemoglobin and enter into the tissue, because your venous saturation should be somewhere in, I think your notes say somewhere in the 65 to 80 range. It should be lots lower than the arterial side if the tissues are receiving oxygen. And you know that if the tissues aren't receiving oxygen, then they're going to go into anaerobic metabolism, and then you're going to also notice lactate. So these two things should truly clue you in that you have confirmed tissue hypoxia. When the venous saturation is elevated and when there's elevated lactic acid production, those are things that clue you in that your tissues are not receiving the oxygen they need and your patient has a problem. Deep breath here for me and hopefully for you. We're going to move on now to the next topic, and that's dysrhythmias. When we think of dysrhythmias, it doesn't matter what kind of dysrhythmia it is. When the patient's heart is not in a normal rhythm, there is always the potential for decreased perfusion. So how do I know that the patient has decreased perfusion to whatever cell, whether it's heart cell, brain cell, tissue cells? first thing, whenever there's a rhythm that's abnormal, you want to ask yourself, is the patient symptomatic? What does the scenario read? Is the patient complaining of chest pain, which would indicate cardiac tissue ischemia? Is the patient dizzy, or are they short of breath? Do they have diaphoresis, cool or clammy? If the patient's in an abnormal rhythm and they're not having symptoms, then you may observe. You may observe. If the patient is symptomatic, then likely you're going to treat. Now then we go to the next question. All right, does the patient have symptoms, and are those symptoms causing hemodynamic instability, hemodynamically unstable patient, as evidenced by, that patient has altered mental status, their blood pressure's low, their oxygen saturation is low, or they don't have a pulse. Again, if the patient is hemodynamically unstable, that's here, yes, we're going to need to treat quickly. That may mean IV push medications or cardioversion or defibrillation. If the patient is not hemodynamically unstable, as in they are hemodynamically stable, but they have symptoms, then it is likely that we can give some IV push medications. Again, that's a lot of here we can do it here we do it here we do it here. And as you learn the rhythms or know the rhythms, you're going to be able to identify what needs to be treated. Again, look very closely at the clues that Dr. Greed gives you in the exam scenario. A lot of students get confused between when do I cardiovert and when do I defibrillate. So let's look at both of these so that you can have a reminder. Both cardioversion and defibrillation are used to reboot or restart the heart. In other words, we want to completely stop whatever electrical rhythm is there in front of us on the paper, and we will hope that the SA node will then restart normally, that they'll be back in a normal sinus rhythm or a normal rhythm. That's the whole purpose of cardioversion and defibrillation. When do we use cardioversion? Well, you can say that you use cardioversion when the patient has a pulse. And cardioversion usually uses lower energy. Well, you're not tested on this, so you don't necessarily have to remember this, but you're going to be a nurse in just a few months, and so you need to realize that lower energy will be used when a patient is cardiovert. To do cardioversion, I want you to always think synchronized cardioversion, because you have to hit the sync button when you deploy the electricity. So here's the process. Let's say you have a rhythm. The patient has a pulse, but they have altered mental status and they're unstable. We want to synchronize cardiovert. We're going to hit the sync button. We're going to figure out how much energy we want to use. And as we look at the monitor, we're going to notice that there are spikes that are placed on the R wave, because we never, ever, ever want to put electricity on the T wave, because that's when the repolarization occurs and the ventricle is resting. Again, if all of this is not making sense to you, go back to the original Hughes Clues Dysrhythmia, the basics, and get your information back up in your head. I've given you a YouTube video so that you can see, because again, I'm just talking about this, and if you're a visual learner, you need to see it. That's synchronized cardioversion. We want to make sure that we deploy the energy on the R wave, and that is how the machine works. Now, when we do defibrillation, that means the patient doesn't have a pulse. We're going to use a whole lot more energy, and it doesn't really matter when we shock the patient doesn't have a pulse, and we need to get them out of this rhythm quickly. Again, another YouTube video. Moving on to the rhythms. How do we treat the rhythms? Well, there's a sheet in your packet that I've put on the key docs, and that's the treatment of unstable rhythms. And I really highly recommend that you know this well, because, and you don't have to memorize it. You just need to put it on your exam sheet, if you're allowed an exam sheet, so that you can kind of have a sense of, okay, here's where I need to go. Here's kind of my map of where I need to go. When we talk about different rhythms, we're going to first mention the bradycardic. rhythms or the AV blocks. And I have them all pictured here. And again, you should be able to identify which one's bradycardia, sinus bradycardia, as opposed to first degree, second degree, and third degree AV blocks. If you don't, you could try and wing it, because I know at this point your brain is overwhelmed with information, because pretty much the treatment for bradycardia and AV blocks, you're going to begin with the same questions that I already talked about. Is the patient symptomatic? If the patient is symptomatic, regardless of the rhythm, well, something needs to be done for that patient. And then again, is the patient hemodynamically stable, or are they hemodynamically unstable? And that will determine some things too. When you look here, you can see that for bradycardia and any of the blocks, sinus bradycardia and any of the AV blocks, your treatment scenario is going to be atropine, or you're going to start a pacemaker. Pacing, there's different methods of pacing, but for bradycardia and the AV blocks, your basic treatment is going to be atropine and a pacemaker. Yes, there is another drug, and that's epinephrine infusion or dopamine infusion that can be given, but that is going to be after these two items don't work. We don't usually use epinephrine first line. Again, because of our select all that apply, you need to just know that with any bradycardia, any AV block, the treatment could be atropine, pacemaker, and if these two fail, then we're going to go to an epinephrine or dopamine infusion. Notice that with pacing, there are three different types: transcutaneous through the skin, transvenous, and then epicardial pacing is only going to be used when your patient has had open chest surgery, such as when they've had a valve replacement or bypass surgery. That's the treatment of sinus bradycardia and AV blocks. Now we're going to move to supraventricular tachycardia, and the picture is below. Supraventricular tachycardia. Notice that this is a regular rhythm. SVT is the only one you're responsible for, and you can figure this out. You have a narrow QRS. It's very, very rapid. Supraventricular tachycardia or atrial tachycardia by our easy peasy name. What are we going to do? Notice the laundry list of things that are given for supraventricular tachycardia. You can do vagal maneuvers. Yes, carotid massage can be done. That's not going to be done by the nurse. That's a physician maneuver, so you're likely not to be questioned about it. Patient can be asked to bear down like they're having a bowel movement. That's the vagal maneuver. Adenosine. Adenosine, and this says 6 grams, but it's not. It's 6 milligrams. Adenosine is going to be given for only SVT, supraventricular tachycardia, and you can repeat SVT. If these drugs don't work, then it could be given some other drugs. That's the ABC drugs that we'll talk about in a minute. Notice the dose. Let's say the patient is hemodynamically unstable with altered mental status, but they do have a pulse. Notice that supraventricular tachycardia, the treatment for that can be synchronized cardioversion. Here's your treatment for SVT: Valsalva, adenosine, synchronized cardioversion. Now we're going to move on to the irregular and rapid rhythms. Irregular and rapid rhythms. Again, here's your treatment recipe. You've got diltiazem. This is the ABCs: amiodarone, beta blocker, cardizem, cardioversion, synchronized cardioversion, or digoxin. These are the drugs that are used for AFib. One of the things that I do mention is that you are sometimes asked, well, which drugs convert the rhythm, which drugs just simply decrease the rate? Notice that synchronized cardioversion, amiodarone, and adenosine are all used to convert a rhythm. They will stop the rhythm, and then they will hopefully reset and begin a normal rhythm. Whereas diltiazem, beta blockers, and digoxin merely slow the rate. If you go back here, you will also see in the testing scenario that you have AFib with rapid ventricular rate, meaning that there's a QRS for a whole lot of these squiggly squiggly electrical currents that occurred in the atrium, and therefore that is usually what will cause the patient's instability, is that the rate is too rapid. So sometimes all we want to do is just slow the rate down, and then some meds increase the rate, and that's atropine and epi. That's just your medication tip. Now let's look at this. This strip it looks like sinus rhythm. I could have replaced it with AFib, SVT, any atrial originated method. And as soon as I say to you, or as soon as you read in the exam scenario that the patient doesn't have a pulse and they're unresponsible, then the name of this rhythm changes to pulseless electrical activity. Pulseless electrical activity. What are we going to do first? Well, you're going to deploy the BLS. So remember, hey, are you okay? Someone call a code. And then you're going to check pulse and then begin CPR. So here's your recipe for pulseless electrical activity. You're going to CPR. You're going to secure the airway. The drug of choice for any arrest situation is always epinephrine. And then what should be considered by the healthcare team? Those are the H's and T's. Again, with PEA, you do not shock because this patient has a rhythm. The rhythm is not the problem. The problem is the heart is not pumping. And the heart is not pumping likely because of one of these H's and T's causes. Look at all listing of them. It's not likely you'll be asked the listing of them, but you need to identify that you've got to treat the causes or you'll be doing CPR and giving epinephrine for hours and hours. That is the treatment of PEA. Now, I could have also listed asystole. Asystole without rhythm. Again, the same treatment as PEA. You might think, well, wait a minute, there's no rhythm there. Why don't we shock? Well, because there's no rhythm. There is nothing to reboot or restart the heart. There is no rhythm. With no rhythm, we don't need to shock at all. We need to do CPR, give epinephrine, and identify the causes. So PEA and asystole, same treatment recipe. Now we move on to another rhythm, and that is ventricular tachycardia. Notice from here to here how wide this rhythm is. This is ventricular tachycardia. But I always say that ventricular tachycardia is kind of like a triple-faced person. There are different scenarios that can occur with ventricular tachycardia. The first one is the patient can have a pulse, and they can be very stable. So the treatment scenario for a patient with ventricular tachycardia that has a pulse that is stable is pretty much the same as if the patient had some random PVCs. You're going to give a drug, amiodarone or procainamide. Amiodarone is first line, pronestal is second line. So these two drugs are antiarrhythmics. In other words, they will get the patient out of this lethal rhythm. They're antiarrhythmics. So amiodarone, procainamide for a patient with stable ventricular tachycardia. That's a patient that has a pulse and is awake and alert. Then there's ventricular tachycardia with a pulse, but that patient is unstable. What are we going to do first? We are likely going to do synchronized cardioversion. Synchronized cardioversion. So look at the recipe. Ventricular tachycardia with a pulse that is stable, or PVCs, amiodarone or procainamide. Ventricular tachycardia with a pulse that is hemodynamically unstable, that has signs and symptoms, that is symptomatic, is going to receive synchronized cardioversion. If you have a patient that has ventricular tachycardia and is pulseless, now you're going to move into this scenario. Always, 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 it's going to be CPR. And again, here's your prompt for CPR, in case you're asked about a BLS question. With any kind of cardiac arrest situation, the drug of choice is going to be epinephrine. You're going to give it every 3 to 5 minutes. You're still going to give amiodarone because we're in this rhythm and we need to get them out. And we can do pronestal if the amiodarone doesn't work. I don't think it's important that you get this whole biphasic, monophasic stuff. We don't care about that. You will defibrillate as soon as the defibrillator is available. Therefore, if you're in a testing scenario and the defibrillator is said to be at the patient's bedside, you're not going to do CPR first. You're going to defibrillate because you want to get them out as fast as possible. If the defibrillator is like where most defibrillators are, it's down the hallway, you're going to start CPR, and then as soon as the defibrillator arrives, you're going to defibrillate it. Notice that I put this other strip here, and this is VFib. So VTAC without a pulse and VFib, again, are the same treatment scenarios. It's the same treatment recipe. All right, that's it for now. Take a break, rest your brain, and then we'll come back and I'll do part 2.